Hello, everyone, and welcome to Inside Healthcare. Drug shortages are a growing problem across America. In this program, we will learn more about this issue and who it is affecting, as well as the very latest on compounding pharmacies and what you need to know about them. Here to fill us in on the inner workings of hospital pharmacies and to give an insight into these issues on drug shortages is Dr. Kathy Schultz. Thanks for being with us. She is the director of the Healthiest Bethesda Hospital Pharmacy, as well as the immediate past president of the American Society of Health System Pharmacy. So thank you so much for being with us,
Thank you for having me.
So let's start with the topic of the drug shortages. What kind of shortages are we seeing? What's causing them?
Sure. Well, the drug shortages that we're facing are primarily injectable drugs that are generics. Those are the most common drugs. So it's not usually drugs that you go to your drugstore and have a prescription filled. It's often the drugs that you would maybe receive in a hospital. And that's why as a hospital pharmacist or a health system pharmacist, we're most challenged with these drug shortages. They're often generic, injectable, and the other thing that is common to these drugs that are in short supply is that there are very few manufacturers that made them.
Is that the cause of the shortages?
Well, there
Or one of
are multiple causes, but that's a large one. We do know that some drugs, the manufacturers went out of business. Other drugs, there wasn't really a market for them, and so they stopped making them. Other drugs, the manufacturers stopped making the product because they had manufacturing problems on their assembly line. And one thing that I've learned through this is that many drugs might be made on the same manufacturing line. And so if the manufacturing line goes down because there's a problem with the technique or, you know, the some problem with the assembly line of the drug, then it affects multiple drugs that are made on that line. And so that's why we see so many injectable drugs, for instance, being affected by this. The drugs that are most commonly impacted are things that we use in surgery, chemotherapy drugs, other drugs that we use for life-saving, for emergencies. So, for instance, epinephrine that we might use in a cardiac arrest situation.
Oh my gosh.
Those are drugs that are commonly in short supply, and so it requires the hospital pharmacy team to really scramble to work with the physicians and the nurses to educate them about what the alternatives are, and see if we can find alternative agents in the same class.
I mean, what if there aren't alternatives?
Well,
There's always an alternative?
there is not, and we've been fortunate that in most cases we've been able to find alternatives. Often we have to pay more for those alternatives because they're not the drugs that we commonly use. But you know, in cases of chemotherapy, for instance, there may be one drug that's the best treatment for your cancer, and there may not be an alternative, and so we have to use the second line agents, and that can certainly be frightening to family members and patients who are dealing with those life-threatening situations.
I was amazed prepping for this interview when I went online to see how many drugs there are shortages. I mean, the list was endless. It just kept going on and on. I could not believe it.
Right. Well, you referred to the American Society of Health System Pharmacists. We've been tracking drug shortages for a number of years, and I believe it was 2007 or so that we started to see a lot of these shortages just skyrocket. The number of shortages that have been identified this year has been lower than in past years, but that doesn't mean the other shortages that were identified in the past have gone away. So the total number of drug shortages is still really high and is still concerning. We're fortunate Senator Amy Klobuchar was one of the champions of drug shortage legislation, so to have someone in Minnesota to advocate for this has been really good for us.
And I mentioned that you're the director of the pharmacy at Bethesda Hospital, and I think a lot of people may not even be aware of a hospital pharmacy. Can you tell us a little bit about the function? You were saying how some of the challenges that you deal with, but what about the function of a hospital pharmacy?
Sure, I'd love to.
Yeah.
First to start with, a pharmacist typically has anywhere from 6 to 8 to more years of training. in order to practice in a pharmacy to start with. So when they graduate, they become registered by taking a board exam, but they also have a doctorate in pharmacy. And many pharmacists go on to take a residency, do a residency in either general pharmacy practice or in a specialty area. So they'll do a general residency and then maybe even specialize in oncology or pediatrics after that. So they're highly trained. The work of the pharmacy, we have kind of just divided into two areas. We have dispensing practices where we need to make sure that the drugs that we dispense are correct, that they're safe, and that they're effective. And then we have clinical pharmacy services where the pharmacists review all the drugs that a patient is taking while they're in the hospital. And one of the things that I always say is that many people don't realize that we're one of the departments that touch every patient who goes
I don't
through our
even
hospital.
think about it. When I was in the hospital earlier this year, I didn't even think about that either, but obviously they helped with my management of pain and stuff after
Right.
surgery.
Yeah, every patient who comes into a hospital gets medications, and so the role of the pharmacist is really important. And at Bethesda, our patients are on a lot of medications because they typically come to us from an intensive care unit at another hospital. And that was one of the things that drew me to work at Bethesda because the patients are so complex and the pharmacists that work there are so expert in managing those complex patients. So it's very challenging, but it's very rewarding.
At the top of the program, we talked about the compound pharmacies, which again, I never heard about them until last fall. It was all over the news. There was some contaminated drugs, injections from New England compounding pharmacy, and several hundred people got sick across the country, some here in Minnesota. There were a number of deaths even. What is the very latest on compound pharmacies? Are we still seeing an issue, a problem?
You know, Jody, that's been such a tragic wake-up call for us. Many compounding pharmacies exist in the United States, and the regulation for those has to be top-notch. We have to ensure that the medications that come out of those compounding pharmacies, it's not FDA regulation.
Which is amazing in of itself. I can't believe that.
It's typically regulated by the Board of Pharmacy when it's a compounding pharmacy. It needs to be to the same standards of quality that an FDA-regulated drug manufacturer would be. And so that's one of the things that we really want to see. And ASHP, the American Society of Health System Pharmacists, has been really at the forefront of helping make sure that this legislation addresses the things that are most important for patient safety, but it also ensures that the practices that we do in hospitals is still maintained. So making an IV is compounding. And we follow very strict standards that are, you know, the Joint Commission or the State Board of Pharmacy have for us in terms of the practice of compounding pharmacies, of compounding medications in a pharmacy in a hospital. We want to make sure that those strict quality standards are maintained as well. Again, we're fortunate Senator Al Franken is one of the co-legislators of some, or co-authors of some legislation on compounding pharmacy. So we expect to see that move forward very quickly.
More stringent regulation and controls?
Yeah, giving the FDA some oversight of those types of pharmacies as well, and ensuring that the quality and the oversight is there.
What should someone watching the show, I mean, how do they know where the medication that they're receiving, injection, is from? What should they be asking? How can they protect themselves or their loved one?
That's really a good question. And not long ago, I had an injection in my shoulder because I had bursitis. And
it's a very personal question.
Yes, and that was a question I asked the physician assistant who was doing the injection was, where do you get your medications? You want to make sure that they get them from a reputable compounding pharmacy or from a reputable manufacturer, ideally, you know, manufactured drug. I think probably 2 or 3 times a day I get notifications that another compounding pharmacy has been shut down because of poor standards. And so you want to make sure that the pharmacy that you're dealing with has a good reputation and has gone through the quality checks that we want to see.
Is there some place that you can go online to verify that information or to check on them or get the information?
I would go to the ASHP website, safemedication.com, for more information. It has a wealth of information for patients and consumers about medication use.
And final comments about drug shortages, compounding pharmacies, hospital pharmacies?
Well, just that it makes our job much more challenging every day. You know, I think we all take very seriously the oath that we take when we become a pharmacist, you know, to ensure the safety of our patients and to ensure that patients receive good medication therapy. And so this is all part of it, you know, managing the shortages, being careful of the compounding pharmacies. It all fits. It's not just, you know, counting pills by 5 anymore. It's a very complex area to work, and I think we're very proud of the fact that we are up to those standards.
And just very quickly, I mean, despite what we've heard about the compounding pharmacies, it's still extremely safe here in America.
It is, yeah.
With the drugs that we're receiving.
Yes. One of the things that we saw several years ago was a problem with some compounded, what was it, from a manufacturer company in China where they manufactured heparin, which is a blood thinner. And they actually showed video of the manufacturing plant, and it was very frightening. So, you know, if we have the FDA oversight of manufacturing here, we're much safer than other countries.
Well, on that note, thank you, Dr. Kathy Schultz, for being with us. Really appreciate it.
Thank you.
Appreciate your time. I know you're a very busy person, so thank you so much.
I appreciate the opportunity to be here.
Thank you. Still ahead, we're going to be talking about kidney stones. They're on the rise. Why is that? About some treatments, so stay with us, everyone. Thanks.
Sooner or later, it's going to hit you that you have to save for your retirement. Do you know how much you'll need? It's easy to figure out. The choice is clear. For a happy ending, choose to save.
See?
Welcome back, everyone, to Inside Healthcare. Kidney stones have become increasingly common in past years, and the rates of occurrence and recurrence are at all-time highs. To start off this segment, we're going to show you one family's story of how kidney stones have affected their lives.
My name is Diane, and I have 5 children. 3 of my children have had kidney stones, and they thought maybe he had appendicitis, had really no idea until finally they were trying to eliminate things, and they did a CT scan, and then they saw that he had a stone that was lodged in his urethra. And so he was in hospital for a few days before they determined that he would not be able to pass the stone, and then he had surgeries.
My name is Melissa. I am 20 years old, and I first developed kidney stones when I was 11 years old. And since I've been 11, I've had over 5 surgeries.
Then Melissa, when she was also 11, we kind of knew probably suspected what it was, but she had the same experience as far as pain, all of a sudden a real onset of pain and blood in her urine, and so we brought her in, and she had a lot more difficult time though with her first surgery because she had a very large stone. It was over 1 centimeter. Allie turns 11 and had her first kidney stone also. She just had a sudden onset of pain at home, and we knew, of course, right away what it was, and brought her into the hospital, and then they did a CT scan and decided that she needed to have surgery also, a perk through the back. So Dr. Portis removed that, and she didn't have to go home with a tube. At that time, they were doing the tubeless, which was much easier to recover from. My daughter went to Bible camp and for a week, and you just worry about them when they're away that maybe something's going to happen and there won't be Dr. Portis hour down the road or something like that. So that's always a challenge. It really is helpful to do the CT scans every 6-7 months so that you can be prepared if there is something, a kidney stone that has developed. You don't have to have the emergency type situation where you're, where they're in pain and you're trying to, get fluids in them so they don't get dehydrated. This way, if there is a kidney stone there, needs to be removed, he can schedule it at a time that works out well with their schedule, and also a time that works with his schedule, and it's not on an emergency basis, which is so much better then they avoid a lot of the pain and all the other things that go along with the situations that we've had in the past. And the other thing with Dr. Portis is, like with Melissa, she had quite a few, I think 5 surgeries by the time she was 11 till she was 15. It was really, really hard on her, hard on us, and then finally he, I think, got rid of all the kidney stones, cleaned her totally up, and she has not had anything now since.
This method is really good, and my surgeries have been really easy, and I haven't had much pain. And now I can go to the hospital and stay overnight and leave the next day. So I'm not nervous going into them. It's stressful and painful having to drink water and take pills and always having the chance of having kidney stones again. And I have to actually watch what I am drinking and stuff.
I guess the way I look at it is there's a lot of families who have to deal with things that are much, much more, much worse. I mean, it has been much easier since we've found Dr. Portis, because he's been wonderful to work with, and I trust him. And part of it is the fear of the unknown when you have different people dealing, you never know how things are going to turn out. So that's really taken a lot of the fear factor out for them and for me.
Well, I mean, everyone has challenges, and this is just one of mine, so.
We'd like to thank the Ramey family for sharing their story with us. Joining us now, we're very pleased to have with us Dr. Andrew Portis. He's a urologist and chair and medical director of the Healthy's Kidney Stone Institute. So thank you so much for being with us.
Well, thanks for having me, Jody.
Appreciate it. I know you're very, very busy, so thank you so much. What is the current state of kidney stone disease?
Well, the stone disease is an interesting, it's an interesting area because we've seen a lot of technical developments, but we haven't necessarily seen that get translated into benefits for the patients. And occasionally we'll have families who come through, like the Rameys, who have very severe disease, and we've developed advanced techniques and technology to take care of them. But one of the frustrating things is always, how do we? They're a rare case, but how do we translate that into things that can benefit everybody? So across the spectrum, we know that the prevalence of kidney stones is increasing, which is thought to be associated with increasing rates of obesity and diabetes in the population.
Never heard that before.
But what's unusual is that the costs of care and the sort of morbidity of care, the impact on the patient seems to be going up faster than the prevalence of disease in the population. And we can get that by looking at how many times patients are into the office, how much imaging they're having, and unfortunately, surgeries and repeat surgeries. So while everything else seems to be getting better, with the stone disease, we're sort of standing still. And I think a lot of that is due to the episodic nature of the stones, where people feel fine until they have an attack. So that when they have an attack, we're really good at controlling their symptoms and taking care of their immediate issue. But if we start looking at, the long term, what is this? When does one attack lead to a second, lead to a third? When does people start changing the way they live their lives because of the stones? How do we get to the root of that? And unfortunately, there's just not consensus on what are the appropriate outcomes that we should be trying to achieve. And because of the unpredictability of the attacks that seem to come out of nowhere, it's frustrating for the patients because they feel great, then they feel lousy. It's frustrating for the docs because they're never quite sure whether they've been effective or not effective. So it's a challenge, and that's something that we're trying to address.
And as we heard in the story with the Rameys, that the Healthy's Kidney Stones Institute is addressing some of those challenges. What is the Healthy's Kidney Stone Institute exactly?
Well, initially we founded the Institute in a virtual format so that we could have a foundation to help with community education. It would provide some infrastructure for research, and about 4.5 years ago we developed it into a full-fledged clinical entity where we're delivering care through that, and our focus is on stone disease. So what we're trying to do is provide an integrated care delivery so that once somebody is found to have a stone, that we take them through treatment and prevention, keep an eye on them on the long term as appropriate for the severity of their disease. And you really need a focused approach to do that. So that's what we do through KSI.
And how is that different than, say, any other place in Minnesota or around the country?
Well, I think anywhere, the docs are always trying to do a good job, but because of the emergent nature of it, it just pops up. And so having continuity with a particular care plan is difficult because you end up at an emergency room that may not be the same emergency room you went to before. You end up seeing a doc on call who may not be the one who you saw before. And it just leads to a fragmented system. So by trying to keep everything, really respect the continuum of care for the patient, I think that's the difference.
And I would imagine, in full disclosure, I should tell everyone my husband had kidney stones, or still has, I don't know, but that you're his surgeon, and he's going on almost 8 years without a recurrence. So the surgery he received is working for him.
Right, and that's what we're trying to achieve, and it really goes beyond the surgery. So from a pure surgical perspective, we can get stones out of most people, as appropriate, but to get that long-term effect that your husband has been fortunate enough to have, I think the key element to that is really helping the patient understand the basis of his disease and be able to participate in self-management. I'm not going to be able to manage him on a day-to-day basis, and I don't think
And I can't either.
he won't allow me. But if I can at least give him the guidelines and make sure that the guidelines are appropriate for him, then it gives him something that hopefully he can build some good habits around, and also liberate him by identifying what his issues are. We liberate him from every time he sees something on the internet about some magical cure or some new thing. He says, no, this is my approach. I stick with my approach, and,
And it's
if
working.
as long as it's working, I'm sticking with it. And if I have a reason to change, we'll change for a reason.
So where do we go from here? What about for patients out there listening that may have kidney stones, or family, loved ones have kidney stones?
Well, what we're trying to do is get away from, or I guess evolve beyond. We'll have a family that comes in like the Ramies, and we try and do our best job for them. We'll have a situation like your husband where it's a single episode of care, and we're able to get him on towards long-term success. But we want to be able to consistently deliver that to all patients, which means being introspective about how we set things up, and it makes we have to tackle issues of accessibility to care, continuity of care, and these were introspective processes that we had to tackle as a clinic to really reach that next level.
And which really fits in with the whole healthcare reform. And I should mention the Healthiest Kidney Stone just has created a standard of excellence for stone care and just received national recognition by the Joint Commission. So first of all, I guess, what is the recognition that you received, and what is the Joint Commission?
Well, what we received was the first in the nation disease-specific care program certification for kidney stone disease.
In the whole United States.
In the country, yeah. So with the Joint Commission's an interesting organization. It's basically a patient advocacy organization that evolved to ensure that standards were being adhered to. And it started off as sort of a quasi-voluntary sort of thing that the hospitals say, well, we want to be accredited, so come by and inspect us. And then that evolved into having all government spending on healthcare being tied to having Joint Commission accreditation. So it transcended from being initially was an opportunity to make sure that you're doing a good job, Now it's the white glove inspectors who come to your hospitals, and if they find a significant break from protocol, they can shut you down. So they got tremendous respect and became a mandatory certification. Later, I think it was about 2002, they developed a disease-specific care program, which started with some major diseases like heart care and stroke care. And initially, again, it was a voluntary program for centers that wanted to distinguish what they were doing and wanted to have some external accreditation that it started off that way, and now you really can't see a heart patient or a stroke patient unless you are certified. So newer programs have come along, and we were the first to develop the program for kidney stone disease.
So being the first, I mean, what do you have to do to even create this? I mean, if it's never been done before.
Well, what was nice is the Joint Commission has certain standards that really are universal common denominators that apply to all diseases, and you need to know what your outcomes are. You need to be transparent in reporting your outcomes, and you need to have a plan to improve those. And they've developed over time, they've developed quite rigorous standards for that and methods to ensure that their certification really does mean something. So for us to partner with the Joint Commission in developing this program was very helpful, because it really gave us the framework to reorganize our program. So we use their program standards, and we supplied our disease-specific experience, and between the two of us, we've come up with a program that I think really helps us deliver care better than what we were doing before.
Really setting the standard for the whole country. So what does this mean specifically for a kidney stone patient or someone with a loved one who has kidney stones watching this right now, to hear that you have set the standard of excellence? What does that mean for them?
Well, what we've identified is 4 specific measures that we think are fundamental to good care for a kidney stone patient. The first is that they should have a reasonable experience of care, which for us often means, since the stones are so symptomatic when they start, is that we're doing a good job controlling their symptoms. Mm-hmm. And the standard we use is whether they're able to get back to their own pursuits. So get back to work, get back to looking after the kids, do whatever. So if you're not in that acute episode, which is usually just a diagnosis, we want to keep you doing the things that you normally do. The second thing is that most stones have an opportunity to pass on their own, but they won't do that unless the symptoms are controlled. So we've taken care of that first, but we want to make sure we're maximizing people's opportunities to pass stones on their own, which means that we provide them the appropriate support, whether it be through medications or through education about their disease, mm-hmm. so they understand it better, so we can get them through that period of time that might be necessary for things to resolve on their own. Now, we do obviously have patients who require surgery for stones that are too large, or situations that are appropriate for it, and there's a very high retreatment rate for kidney stone disease, and in part it's due to multiple stones in multiple locations and people's specific things, but our goal is that if we're going to do surgery, we should really only do surgery once. So, and the 2 kidneys end up being a little bit like 2 different people. So for a left kidney or a right kidney and the drainage system, we want to make sure if we're going to do a procedure, we get everything on that side. So it means selecting the appropriate procedure to get that done, doing it safely, efficiently, and effectively. Finally, where we get to with your husband is we want to make sure our 4th and final measure is satisfied, that patients are well set up to manage their own disease. And part of that starts with us, where we have to identify what the appropriate risk factors are and a way to minimize those. And the other part really ends up being on the patient, of understanding their disease, which we play a part in supporting, but really send them forward armed for success.
Well, very interesting. I can hear your pager going off, so we'll wrap this up so you can get back to taking care of some of those patients. So thank you so much, Dr. Portis, for being with us. We appreciate it. Thank you. And we'd like to thank you for joining us. Thanks for joining us this time, and we hope you'll join us next time on Inside Healthcare. We'll see you then, everyone.
Inside Healthcare. For more information, visit stjohnshospital-mn.org or call 651-326-7800.